reference structures really are things that, they're anatomical structures that are pretty much common to everybody or most people.
Mhm.
So these are things that, really don't change in most of us. And so we use these as kind of fixed structures or fixed areas where we're going to use them in order to be able to find other structures in the surrounding area. So the way I always describe it when I do these seminars is it's like going to a city and you're using some of the big landmarks, and you're going to use those big landmarks in order to move around the city. So we're doing the same thing now where, whether it's the shoulder, the hip, or any other part of the body, we're using specific structures that are easy to find. They kind of stick out, right? And so we're using these structures in order to be able to move around and be able to palpate some of the surrounding tissues as well.
So
So
really,
that's one of the things that we use is reference structures.
okay, continue then.
The other thing that we look at is fiber direction. So you talked about anatomy, and so being able to understand anatomy to a certain extent and understand how tissue fibers kind of move, because they tend to move in a certain way. So the bicep is not going to move, left to right. It's always going to go up and down. So we have an idea of which way that fiber direction is. It might change slightly on everybody, but using a reference structure and getting onto that bicep, then we're going to be able to use fiber direction, knowing that it goes in north to south direction, that we're going to move in that direction in order to find the bicep.
Mm-hmm.
Okay.
Okay, so that's what. So we have reference structure. For example, once I can convince someone that they are on the distal bicep tendon, it doesn't take much to have that person kind of move into pronation, and you kind of fall into that depression, whereby if you hook on the medial side of that depression, you're hooking on the pronator teres. So from there, you can move. You can, utilizing the fact that these muscles are wrapped in this epimysial layer, this outer connective tissue. The fact is that the density of that outer tissue kind of makes tissues feel like they're in sausage casings. And sausage casings, because they're dense, they live next to other sausage casings, which allow something that we talk about in our courses, the identification of epimysial grooves, or the grooves between these bundles. And that allows us to identify, something as small as, we have rectus carpi, or flexor digitorum, flexor digiti minimi, flexor carpi ulnaris. Depending, if you know the anatomy, you know what structures lead to the expression of the directionality, as you alluded to, you can find very small things, extensor digiti minimi versus extensor carpi ulnaris, which is ECRM. All of these things are palpable from an anatomical standpoint based on their anatomy. We talked about reference structures being one of those things. One thing that the last thing probably we should talk about is the idea that layering is also an important concept. So when we're teaching palpation, what do we, maybe you can talk about layering and how that factors in.
Sure, because I mean, people, this is where we go back to, palpation, people downplaying palpation, because some people, or, maybe some research doesn't show us stuff at a deeper level, and people tend to use the psoas as an example here, and we'll get into this a little bit later. But people, because, there's discrepancies between palpation of the psoas, for example, they kind of discard palpation altogether. And I think that's a huge mistake. Having a systematic way of looking for things, so assessing and using palpation to do so, if it's done in a systematic manner, there's research that's provided that shows us that, yes, it can be very reliable. So for more superficial stuff, we have epimysial grooves, like you said, we have fiber direction, and these are going to be very important as far, as well as reference structures. When we get deeper, this is where the problem happens. So as we get to the deeper structures, we need to be able to use some type of layering to get to these tissues. And this is where, people make the biggest mistake, I think, when it comes to palpating, is that if they're going to try to find something a little bit deeper than, the more superficial stuff, they're just going to smash tissue, kind of like power drive right through everything to get to the deeper stuff. And, that's not a way to assess, because all you're going to do is you're going to hurt somebody, you're going to treat pain, you're going to treat tenderness, and that's not an outcome measure that you want necessarily, right? So what's going to happen is that you're going to get a false positive because somebody's going to have pain just because you're pushing and smashing tissue, and not because really there's a problem there.
Mhm.
So when it comes to layering, and we use what's called layering technique in our courses, what we want to do is really what you're doing is that you're trying to decrease the resistance of the more superficial tissues in order to get to the deeper stuff. So
Mhm.
what I'm trying to do is use less force to get to the deeper stuff so that I don't inflict any pain, so I don't create a compressing and a jamming of tissue, instead of slowly getting to the deeper stuff and being able to then assess those deeper layers.
So this is important. I'm going to kind of pause and talk about one thing here because, again, we keep alluding to this idea of people who are, in our opinion, trying to find problems with the concept of palpation. But I think it goes without saying, but maybe we should say it, is that we don't think we're ever directly palpating anything per se. Like when I say I'm palpating the bicep, everyone should understand that I'm palpating the bicep indirectly through my contact, through the skin, through the fascia
Right.
superficialis, through the fat that lives in those layers, onto that profunda, and then through the fascia profunda onto the epimysial layers, etc., going deeper. So everything's an
Yeah.
indirect palpation. So let's start with that. So when we talk about palpating deeper structure, multifidi, for example, um, tibialis posterior would be another example. Of course, you're unable to move your way through the superficial overlying gastroc and then shimmy your way through the soleus and then touch the tibialis posterior. No one's saying that. Um, Straw manning these arguments happens a lot, so that's why we have to explain. Clearly, no one's saying that you are doing that, but there are ways to prepare the environment such that we have the best ability to indirectly get as close as we can to the tissues that we are attempting to palpate. And one of the ways that we do this is by layering. So let's hold psoas off for another conversation because that causes so much anger for whatever reason. We'll go back to the triceps surae group, where people tend to often mess up is, I'm treating the person's leg is perfectly straight and they're prone and they're effleurage or whatever they're doing, and they're treating gastroc. And then they do the exact same movement. They say, well, now I'm treating soleus. And their concept is that I'm kind of pushing harder to get there. Now, what we're saying is that if you utilize your anatomical knowledge, you understand where the vast majority of tissues originate and insert. Of course, we don't like the concepts of origins and insertions, but there is, to a large extent, fibers that insert and originate from in different areas. If we're familiar with these concepts, there's ways for us to layer our way down whereby we can get the tissue to be as pliable as possible by shortening the tissue. The example in the triceps surae group is if you want to get to the gastroc, by all means, go right through the skin with the leg straight. But if you want to go through that soleus, it would behoove you to bend that knee. Considering the gastroc covers two joints, the soleus covers one. By bending the knee, you are taking that gastroc and now it is in its most pliable state, whereby lower amounts of compression will lead to dissipation of water content, allowing that gastroc to be as thin as possible so that you can palpate the underlying structure of the soleus through the gastroc. If you want to go one layer deeper, then it's a matter of playing with the pronation of the ankle, because now we want to do the same thing with the soleus in order to get to that tibialis posterior. So there's ways to manipulate the anatomy in three-dimensional space in order to improve our capabilities of palpating that underlying tissue.